Thank you, Dr. Babar Salim, for an enlightening session. Before we introduce our next speaker, I'd like to remind the audience to kindly switch off your mobile phones to avoid any disturbances. The next speaker is Professor Dr. Kamran Cheema, who is a retired professor of pulmonology at Services Institute of Medical Sciences, Lahore. Dr. Cheema will be speaking on connective tissue disease-related interstitial lung diseases.
Thank you. I'd like to thank the Society for inviting me to talk about interstitial lung diseases and connective tissue diseases. Connective tissue disease-related interstitial lung disease is interstitial lung disease that develops in someone that either has a proven connective tissue disease or can be classified as having an interstitial lung disease. There is another term called interstitial pneumonia with autoimmune features, IPAF, people who don't have full developed connective tissue diseases but may have Raynaud's, positive ANA, positive, and they tend to do a little better than patients with idiopathic pulmonary fibrosis. Of all the parenchymal lung diseases and interstitial lung diseases, connective tissue diseases are responsible for about 15% of all the ILD patients that we see. The incidence of ILD in connective tissue diseases varies from disease to disease. The other common ILD that we always compare with is idiopathic pulmonary fibrosis, but we sometimes see other patterns like NSIP, cryptogenic organizing pneumonia, and lymphocytic interstitial pneumonia in patients with CTD. So if you have a patient of autoimmune disease and they come in with acute breathlessness, you are probably not dealing with an interstitial process, you're dealing with an infection. And more recently, we've seen a lot of COVID in patients, in your patients who were on immunosuppressants, getting worse, coming in with GGOs, having CTs. That would otherwise sometimes confuse us with interstitial diseases, but these patients have diffuse damage. Patients coming in with a subacute presentation could have some allergic alveolitis superimposed on their disease, and the ILD patients are more of chronic presentation, but you can have acute flares of chronic disease. So what are the ILD patterns that we commonly see in CTD? In scleroderma, about 30% of the patients have severe ILD, and they have a 10-year mortality of 40%. The commonest pattern is an NSIP pattern, and we'll talk about that, followed by UIP and DIP. In RA, about 2 to 8% have severe ILD. But if we did active CTs to look for disease, we would see interstitial lung abnormalities in about 50% of them. They don't yet meet criteria for ILD, but they have interstitial abnormalities. The commonest pattern is UIP, and these two terms I'll try and explain, followed by NSIP, organizing pneumonia, and diffuse alveolar damage. In the myositis, up to 50% of patients may have ILDs, and a higher incidence of organizing pneumonia and NSIP. Sjogren's, NSIP more common, followed by LIP, and also an SLE. So why do we keep switching these terms, UIP, NSIP, NSIP, UIP? UIP is a classic CT appearance, but it is so classic that if you see it, you don't need histopathology to confirm the diagnosis. This is what we used to call interstitial pulmonary fibrosis. It was also called cryptogenic fibrosing alveolitis. And this classic CT has subpleural basal predominance with a lot of reticular abnormality causing honeycombing, and later on causing traction bronchiectasis. This distribution is the same distribution where we also see COVID. And now we see people with breathlessness who had COVID, who have subpleural interstitial abnormalities, and we wonder if they had an underlying interstitial lung disease which flared up after COVID, or these are all post-COVID related changes, and we're still trying to figure that out. But the other common term is NSIP, which is more of an upper and mid-zone predominance with a peribronchovascular predominance, more ground glass than UIP, may have micronodules and discrete cysts, other than areas of honeycombing. Eventually, all diseases lead to, if they progress, lungs which are fibrosed scars and which have big holes in them. And so it's difficult to tell at that time what the disease was when it started. But we want to catch them early. This is your classic UIP. It is peripheral, reticular, developing honeycombing at the bases, very symmetric, and it is a fibrotic disease. Whereas NSIP, asymmetric, more around the bronchovascular bundles and more of an inflammatory disease, hence being treated with anti-inflammatory agents. And the distinction is sometimes difficult even for skilled radiologists and pulmonologists. And many times you biopsy patients, we used to biopsy patients, and some of the patients with NSIP after a biopsy got reclassified as actually having a UIP sort of a picture. But this is organizing pneumonia where you have areas of consolidation, more commonly seen in your patients with polymyositis and inflammatory myositis, and organizing pneumonia. This is diffuse alveolar damage due to, could be COVID, could be any vasculitis. So why do we keep emphasizing UIP? The reason is that before 2012, life was simple. We gave everyone steroids, we gave everyone azathioprine, and although we didn't know that we were helping or hurting them, that was sort of standard. So whether it was an autoimmune disease with ILD or ILD without autoimmune disease, that's what we did. And then somebody said maybe an acetylcysteine will be a game changer. And a trial was done using azathioprine, steroids, and acetylcysteine versus only acetylcysteine. And we found out that we were killing more patients by giving these patients steroids and azathioprine. So that sort of changed our thinking about UIP, that immunosuppressants are not to be used in patients with UIP. In fact, they are harmful. Later on, we found a couple of treatments that are helpful, and we'll talk about that. But that is why it's important to differentiate the pattern, and if we can do that on the basis of CT scan, we can avoid giving toxic therapy to our patients. But on the other hand, the window of opportunity for treatment in ILDs is very narrow. Once the patient has developed fibrosis and scarring of the lung, no treatment is going to undo that damage. So the treatment for interstitial lung diseases are mostly aimed at preventing the decline in lung function. And we know that for that, we need to start treatment early. In approximately half the patients, the most rapid decline occurs within the initial 3 years of disease onset. So we need to do something in the beginning to prevent that damage, but we didn't know what it was that we needed to do. And we found out that what we were doing was not the right thing. But having said that, your patients, because this session is about rheumatoid arthritis, just looking at the disease and survival with similar level of interstitial lung disease, similar level of DLCO, patients with IPF had the worst prognosis. Those with RI, rheumatoid arthritis, and UIP pattern, IPF pattern had somewhat better, and non-IPF pattern had the better survival. So the worst interstitial lung disease to have is UIP. And if you get it in the setting without having concomitant rheumatoid autoimmune disease, then your prognosis is perhaps the worst. So we know that certain antibodies like anti-centromere, anti-topoisomerase are markers for patients to develop more severe interstitial lung disease. We know some of your patients with inflammatory myositis sometimes present, or anti-synthetase syndrome present with very rapidly progressive interstitial diseases. It is recommended that all patients have baseline PFTs, and any patients with cough or breathlessness have a baseline HRCT. For detection of early disease, it is sometimes necessary to do a prone HRCT because supine CTs get hypostatic changes and they can be confusing. So for early disease, a prone HRCT, but HRCT is obviously expensive. Is there a cheaper alternative? Well, an ultrasound can pick up. There is a study looking at systemic sclerosis and doing a bedside ultrasound to pick up peripheral disease. And actually, if you see a lot of disease, you can predict that that patient will have a worse outcome. So ultrasound as a substitute, if you don't have a CT, you can consider it. Now, the treatment, who to treat and when to treat, depends on the nature of the disease, depends on whether we have an effective treatment for that type of disease, and whether the patient's disease is progressive. So no need to treat people who don't have a progressive disease, no advantage to treat people who have now developed end-stage fibrotic disease. So in between are people whose disease is progressive, where we now think we have some treatments and we can consider treating. So what are the options? These are some of the major trials. I'm sorry, these are too small. Everybody knows about the scleroderma lung study, which looked at cyclophosphamide, showing that cyclophosphamide reduced the rate of decline of lung function in systemic sclerosis, ILD. This was followed by the systemic sclerosis 2, which compared mycophenolate with cyclophosphamide, showing that they were comparable, and because mycophenolate had fewer side effects, that became popular. The study was done with oral cyclophosphamide, but because of less side effects with IV therapy, that became the common practice. But interestingly, in spite of both these things, neither cyclophosphamide nor mycophenolate is approved for use in scleroderma, according to the FDA. It is used, it is the standard that every treatment is being compared to, but it is not approved by FDA. And there were trials of pirfenidone, which either were stopped in COVID or the data has not been shared. But there is one trial of nintedanib that I would like to talk about. And then we have trials of tocilizumab, an anti-IL-6 drug being used in scleroderma, which did not help. In both of these trials, it did not help the skin changes, but it reduced the rate of decline of FVC. So nintedanib is an oral tyrosine kinase inhibitor, which was approved for use in UIP, interstitial lung disease, non-connective tissue related, which, as I told you, has worse prognosis than connective tissue-related disease. This was used in patients with scleroderma, and it reduced the rate of decline of FVC. Interestingly, the rate of decline in the placebo group was only 93 ml per year compared to the rate of decline of 200 ml per year in our patients who had IPF. So already you're looking at patients with, and these are patients already on treatment with mycophenolate, half of them. So nintedanib got approval for use because it reduced the rate of decline of FVC. It did not have any effect on the benefit on other manifestations of systemic sclerosis, and it causes GI side effects. So if it were to be available here, and it is not available yet, and when it will be available, it will be expensive, but this is a drug that we could use across the board. This is the trial of tocilizumab, again showing that although it didn't improve the skin manifestations, it improved it decreased the rate of decline of FVC. So for systemic sclerosis, we have mycophenolate, cyclophosphamide, and we can use rituximab, now tocilizumab, and nintedanib are approved. For RA, we were concerned that methotrexate and leflunomide were causing ILD, but now we have changed our thoughts. We now think they actually prevent ILD if given early. And for your inflammatory myopathies with more rapid diseases, that's where we need to use steroids along with a combination of either rituximab, cyclophosphamide, IVIG, or plasmapheresis. This is just one trial I wanted to show because the time is short, of stem cell transplant. These were patients with systemic sclerosis who had severe disease, but they did not have pulmonary hypertension, they did not have cardiac disease, and two trials showed some benefit of stem cells. So a larger trial, the Scott trial, was done, and this is actually looking at all the patients. 3 patients in the transplant group died before getting transplants, but at 2 years, the patients with transplant were doing better than the patients who got 12 months of cyclophosphamide. This was obviously being done in a center which excels in doing stem cell transplants, and the mortality is much lower, but this is intriguing. The criticism of this study is that the patients in the cyclophosphamide group got 12 months of cyclophosphamide, and maybe if they had been given more therapy, the results would not have been this different. But this is intriguing, and I think these are some of the other ongoing trials, some of which have been completed but not published. This one was stopped, the one with pirfenidone, because they could not recruit enough people. So in this era, how do we take care of our patients with ILD? This is the era of precision medicine. We have to weigh the risks of our treatments. They're very toxic and expensive treatments, and it is surprising that older treatments like cyclophosphamide and mycophenolate do not have FDA approval for use in systemic sclerosis, but the newer, more expensive treatments like tocilizumab and nintedanib have been given FDA approval for use in ILD related to connective tissue disease. We have to pick the patient with more progressive disease, and for that we use the DLCO less than 70%, breathlessness, fibrosis score of more than 20%, FVC less than 70%, or a rate of decline of FVC of more than 10%, to pick up those patients who are likely to progress before we give them toxic therapies. And while we do that, we need to focus on the comorbidities, because these patients can have vascular diseases, sleep apnea, diabetes, osteoporosis. Young patients have fertility issues. And based on that, we need to decide if a patient needs to be treated, and if they need to be treated, what treatment to give them. Just briefly, pirfenidone inhibits growth factor and was approved for use in UIP based on these trials, where it reduced the rate of decline of FVC in patients with IPF. And nintedanib, a vascular endothelial growth factor receptor inhibitor, again approved previously for UIP in 2014, and now approved for use in CTD-related ILD. Just a last line about the role of bronchoscopy in these patients. We need to rule infections mimicking ILD. We need to rule infections before starting biologics. We need to rule out infections developing in patients on biologic to diagnose diffuse alveolar hemorrhage. We only do transbronchial biopsies to exclude conditions like hypersensitivity pneumonitis or sarcoidosis. And for that, cryoscopic lung biopsy is replacing the transbronchial biopsy. It can be done in Lahore. Not every patient with autoimmune disease has interstitial lung disease. This girl was being treated with steroids for what was an autoimmune disease. They didn't know about it, but this is a classic pattern called crazy paving pattern. This girl actually had alveolar proteinosis. So we were able to make the diagnosis on bronchoalveolar lavage, and then we did the whole lung lavage, and all this proteinaceous junk, this is coming out of her lungs. And she came in on 3 liters of oxygen and left the operating room after 7 hours on room air. So sometimes we need to take a minute and pause and decide whether the patient actually has interstitial lung disease, or we are just giving the patient toxic therapies. With this, I'll stop because I've been reminded that time is over. And I'm sorry I had to rush through a few things, and if there are things that I didn't touch upon, I'll be available for questions now or later. Okay, thank you.
Thank you, Dr. Chima, for such an informative session. Our next speaker for this session is Dr. John Axford, who is a consultant adult and pediatric rheumatologist and a professor of clinical rheumatology at St. George's in London. Dr. Axford will be conducting a special PCR 2022 clinical quiz.
Terry's told me I've got to walk up here without a limp, so how was that, Terry? I hope that looks better. Here I am here. And we want to know what was in those pots, so perhaps someone could ask that question at the end there. Was it all pus? So thank you very much for welcoming me back, or inviting me back. As we were told last night, not many people come to Pakistan, but when they come, they keep coming. And I'm one of those people that keeps coming to Pakistan, so thank you very much for your hospitality. I'm sandwiched between rheumatoid arthritis, so I'm obviously here to sort of get your brain going again and get you thinking and stop you from sleeping, although it's so cold in here, it's very difficult to sleep. It's always the same that when you put together a couple of clinical cases to present, then the clinical cases that come before your clinical cases are virtually exactly the same. So you have no excuse not to have the answers. So this is billed as the clinical quiz. So the first couple of cases are to do with histiocytes. And this is a 35-year-old lady who presents, and this is quite a lot of similarity here, isn't it? Weak autoimmunity, Asian ethnicity, general malaise, fevers going up to 38 degrees, transient rashes, itchiness, facial erythema, and cervical lymphadenopathy. So she had 4 large 0.5 centimeter cervical lymph nodes. Well, we just discussed it, didn't we? So what's the diagnosis? This is the list, and Sammy quite rightly pointed out tuberculosis up here somewhere, down here, lymphoproliferative disorders, autoimmune type diseases, and then all the other small print stuff down at the bottom here. So where do you think we're going here with this lady with a little bit of autoimmunity? Does she have an autoimmune disorder? Normal full blood count, atypical lymphocytes, and an acute phase reaction. So this is a lymph node biopsy here, and you can see this is normal bits of lymph node, and here you've got areas of necrosis. So you've got granulomas here, you've got histiocytes here, and areas of necrosis. So the histopath report read karyohectic debris, histiocytes and macrophages, and crescentic mononuclear cells. Anyone want to hazard a guess? We've just spent 10 minutes talking about it this morning. And here we are. My colleague said we should do some immunohistostaining, and this is CD68 staining, which goes for the macrophages, the histiocytes, and these are the histiocytes here, and this is the area of necrotic chain. So you've got acute necrosis going on generated by histiocytes. So is it the autoimmune problem? Is there something else going on here? Is it infection? So the diagnosis is histiocytic necrotizing lymphadenitis, otherwise known as Kikuchi disease. So always think about these things and don't get phased by other things that go on in other people's lives. So this is a T cell and histiocyte response to an infection, such as EBV, young women, and ethnicity probably varied, but the literature suggests Japan and Asia, hence my comment that your patient probably had this disorder rather than autoimmune disease when we went over her this morning. Lymphadenopathy, fever, rash, arthritis, fatigue, and hepatosplenomegaly are hallmarks. Time and reassurance, as I keep saying in my clinic, so what is necessary here, and generally one doesn't have to go down the road of immunosuppressive treatment, But it's a self-limiting disease. Be aware of it, and be aware of associated autoimmunity. So the next case, and this person actually did just walk straight into the clinic, a 38-year-old Ethiopian, and he had a 2-month history of multiple nodules, left deltoid, hamstring muscles, dry mouth, eyes, poor appetite. So he flew in from Ethiopia, loss of weight over this period of time, 19 kilos over 2 months, nocturnal fevers, glandular swelling, shortness of breath on minimal exertion. And for a young guy, he had an enormous comorbidity here, which is totally irrelevant to the diagnosis, and he also came on a ton of medication. So you can see how you can get quite sidetracked by some of these people and wonder, what the association is between some of these disorders. And of course, a family history of cardiovascular disease here. Any thoughts on a young man presenting with systemic features and lumps? Well, of course, you immediately get worried, don't you, when you phone up the sarcoma clinic at the Royal Marsden or the equivalent in Lahore, you wonder what on earth's going on with this patient. Sometimes the more dramatic presentations, the less dramatic the disorder. So examining him, very well built young man, multiple non-tender nodules, calf muscle and left deltoid. Any suggestions? We discussed this morning. This is what he looks like here. So this is a great big lump over the leg down here. Non-tender, enormous lump. You see large lumps over the deltoid here. And I was really thinking, what on earth can this be, his forearm down here? What are we going to do? Any thoughts? Can someone say what that was? Top of the class. So, what further investigations would you like me to do or tell you about? Quite right, so we do an MRI, and these show these large nodules in his muscle here, numerous enhancing lesions throughout the musculature. I think Ali, if he's in the audience, probably did the MRI and reported it. So here we are showing confluent mass of granulomas, and they coalesce here to form nodules. And from up to date, these were several centimeters in size, but this is what we got back from the Royal Marsden when I sent him up there for further evaluation. So multiple confluent granulomas, histiocytes again, macrophages again, multinucleated giant cells, neutrophils, no caseation, no tuberculosis. So what investigations results haven't I told you about? Ticking the boxes here. So chest x-ray, he had bilateral hilar lymphadenopathy with interstitial lung changes, and he had a raised angiotensin converting enzyme. And that's why I was querying sarcoid this morning, because the granulomas make the ACE. And this is the bilateral hilar lymphadenopathy, made up of nodules. So the diagnosis, as my friend here quite rightly says, sarcoidosis, which is what we were discussing earlier on this morning. So extrapulmonary sarcoid occurs in 30% of patients. 25% of these patients have cutaneous sarcoidosis, and this patient here has nodular subcutaneous sarcoidosis. And as usual, we always like to give this a difficult name so no one knows what language we're speaking, and this is called Daré-Roussé sarcoidosis, 1 to 12%. So really pretty rare, middle-aged, so we got it wrong this time. Female, we got it wrong this time. Predisposition to autoimmunity, so one has to keep one's mind open. But if you tick the boxes, you go through your evaluation scheme, you work out the diagnosis at the end, and this guy did very well with very, very little intervention required. So this is another patient with similar issues to a patient we discussed, the third case this morning, and I called it, just to confuse matters here, chondrocalcinosis and furniture making. Or manufacturer, the occupation had very little to do with her problem, but she was a fairly talented furniture manufacturer. And again, as I mentioned yesterday, systemic features very, very common in in rheumatology, increasing pain, stiffness over a short period of time. And she was sent to me, I think there was something else going on with her, shoulder and pelvic girdle and knee stiffness, long car journeys, difficulty. No peripheral synovitis, but she said she felt generally well. So systemic features of stiffness. Is this mechanical? Is this systemic? Examination, axial scoliosis, concave to the right, and significant reduction in hip range of movement. This is her back here, so you can see the scoliosis convex to the right. Convex to the right? Concave to the left. Got that bit wrong, didn't I, I think? There it is there. So significant osteoarthritis going on in this patient here. And I don't know whether Ali is in the audience, but significant osteoarthritis, but there's this odd fluffiness of the bilateral greater trochanters, and I think this goes with chondrocalcinosis, and this is calcium pyrophosphate deposition in this patient here, causing significant inflammatory osteoarthritis. These are some leg x-rays here, and you'll see at the top here, patient has significant chondrocalcinosis in the knees. And this is why she was experiencing increasing knee stiffness, joint stiffness, car journeys were difficult. So this is more of a mechanical inflammatory problem rather than a systemic inflammatory problem, such as with polymyalgia rheumatica. So just to review it here, x-rays, bilateral hip osteoarthritis, chondrocalcinosis. And the reason why I'm telling you this is telling you what is going on with her, but telling you what she hasn't got. And this is something else that we discussed this morning. So this is a diametrically different DEXA scan from what we saw this morning, and that her bone density is up here. So her total axial spine T-score was 4.2. So significant increase in bone density. So summary here, bloods in this 45-year-old lady, no inflammation going on in the body, so the stiffness, etc., is not systemic. Immunopathology negative, but you can see she's got a normal calcium, so we're not dealing with disorders associated with decreased calcium, and an increase in phosphorus, okay. So an increase in phosphorus, normal vitamin D, and a low alkaline phosphatase. So normal calcium, increase in phosphorus, and normal alkaline phosphatase. Anyone going to jump in here and suggest what may be going on? Not my friend in green. I didn't quite get that, but we'll. So here I am just emphasizing again, elevated alkaline phosphatase, reduced calcium and phosphorus, radiographic findings. Sorry, this is if you get osteomalacia. So this is a common thing here. So she had a reduced alkaline phosphatase. She had normal calcium. And this is why we're talking about codfish vertebra and why I thought this patient that we presented this morning, the differential could be osteomalacia and pseudo-fractures. And this is why I was emphasizing her bones were quite normal. There were no pseudo-fractures. She had osteoarthritis in the back. She didn't have codfish vertebra, and her biochemistry was totally different. So just to remind you, this isn't a case of osteomalacia, although it may be associated. So other investigations you would do, but of course the first thing you would do, and I had to look this up over breakfast because I had forgotten all about it, is you'd look for a phosphatidylethanolamine level, something that we always do and is readily available in the lab. But this is the most common lipid that sits in our cell membranes, and I guess this was picked as a marker for total disruption of cell biochemistry because it's elevated. Vitamin B6, pyridoxamine, was low in this patient. Sorry, was highest in this patient, greater than 250. So you've got a high level here. These are markers of this disorder, and a decrease 24-hour urinary calcium. So as I said, phosphatidylethanolamine is a very abundant lipid associated with intrinsic cellular metabolism and a pivotal member of the cell membrane here. So likely diagnosis, this is what we've got here. Normal calcium, raised phosphorus, reduced alkaline phosphatase, increased phosphatidylethanolamine, increased vitamin B6, decreased 24-hour urinary calcium. All coming together. What disorders associated with these biochemical findings? With increased osteoarthritis, chondrocalcinosis, no fractures, and significant high spinal bone density. This lady has hypophosphatasia. I don't know whether you said that, but this is a metabolic bone disease, and it's all to do with a defect in tissue non-specific alkaline phosphatase. So they don't have alkaline phosphatase, and it all goes wrong. And what they get is premature loss of teeth, they can get osteomalacia, and they get significant calcium pyrophosphate deposition and arthritis as a result. This is a photograph taken from a textbook showing loss of dentition in a patient with hypophosphatasia. And as is always in these disorders, there's a spectrum, and my patient was at the good end of the spectrum, and she was suffering from the mechanical issues, so daily physiotherapy and NSAIDs. This is an interesting drug here, aspartase alpha, which is a means of putting back the alkaline phosphatase into the cells, and this is what they use in the children that have this disorder, which can otherwise be quite devastating, and indeed it works. So 3 clinical cases to enliven your minds. Other recent developments in rheumatology, this is called John's weather forecasting stone. So when the stone's wet, it's raining. When you can't see the stone, it's foggy. And when the stone's gone, there's a tornado. Thank you very much. Thank you very much.
Thank you, Dr. John Oxford. I'd like to announce that we have been joined by our Honorable Chair, Professor Dr. Naeem Afzal, who is a Professor of Medicine at Fatma Janam Medical University, Lahore.
Thank you, sir, for joining us. I would just like to make an announcement that for all the executive members who are sitting in the hall, we have made a facilitation desk for the executive members at the back of the hall. And in order to, you can check your yearly dues, and if they are pending, please submit the yearly dues before the start of the AGM. We just have a break of 1 to 2 minutes before the last talk.